Previously on CSWN, we have mentioned before the fact that resistant hypertension is a problem and it's one that is not going away. We also have talked about the fact that, at least in one European study, there were a number of patients who, right before they underwent renal denervation, they were evaluated one last time only to find that they really did not qualify. So with resistant hypertension, such a problem, in the March 4th issue of JACC, there is a paper, Therapeutic Drug Monitoring Facilitates Blood Pressure Control in Resistant Hypertension. And I'm with Dr. Wanpen Vongpatanasin, and Professor of Medicine and Director of Hypertension at UT Southwestern Medical Center in Dallas. First off, how big of a problem is resistant hypertension?
It's a major problem, actually. As we have more drugs available for treatment of hypertension, the good news is the number of people who control one or two drugs may be improved, but the population with resistant hypertension actually has doubled in the past 5 to 10 years to the amount of between 12 to 20% of all hypertension have this form of resistant hypertension.
Now, one of the reasons why that study in Europe was suggesting that these patients didn't qualify was because they were not taking their meds as they should have been. Mm-hmm. Another reason was sometimes they simply were not on optimal therapy. Mm-hmm. How common is it that patients are not adherent to their medications, mm-hmm. and is that causing a problem?
Yes, we began to looking at this as well. The adherence to antihypertensive medication, just like many chronic diseases, is a major problem. And reliance on the self-report by the patient alone sometimes doesn't reveal all the prevalence. And doing the pill count or looking at the pharmacy is not always easy because sometimes patients forget to bring the pill bottle. And more recently, studies from the European countries has begun to use therapeutic drug monitoring either in the serum or in the urine to look at the blood levels. And they found that more than 50% of the patient who quote-unquote have resistant hypertension actually does not take at least one or two or all of the medication prescribed. So it's a major problem, and we began to look at this as well in our cohort to refer to our insured patient who refer to our clinic. And we found quite very similar numbers of patients who's not adherent to treatment.
So in this paper in JACC, what were you looking at specifically?
Well, we use drug levels in the serum for the patient who refer to see us. So we do the blood levels. These are actually covered by the insurance and have a dedicated CPT codes. And many practitioners might not be aware of this, but we use that. And actually, we're not using that part of a randomized clinical trial. This is just, we're already routinely doing this. And we found that 54% of the patient that we look at has at least one undetected drug which they're prescribed to take. And so I think that's quite an amazing number of patients as well.
Now, were these patients who, when they were told that they might not be taking their medicines, were they, I've been taking my medicine, or did they fess up?
All of them, actually, when we test the patient, all of them say they're taking the medicine as prescribed regularly.
Of course they do.
Yes. So if they say that I don't take them, we didn't actually order it because there's no point doing that if they already admit they're not taking them. We're doing it only in the patient who say that they take everything supposedly as the prescribed. And I think still majority of the patient, it's unintentional adherence because sometimes we always feel like we're doing a lot better than what we think we do in terms of in everything in life, like in terms of exercise, diet. We always think that we're doing a lot better than what we're supposed to do. And when we found out about non-adherence, we were able to give them a feedback, which actually helped them a great deal. It's not only we uncover the non-adherence, but make them aware of how much non-adherence that they have. We were able to look into barriers to non-adherence in terms of side effects that they forgot to tell us, or that really bothered them, and somehow they didn't want to tell the doctor, or that there are costs. And sometimes insured patient doesn't mean they can pay for all the co-pays. So by knowing those information, and we adjust the medication to the point they can take them, we were able to lower the blood pressure for the first time to the non-resistant range.
Now, given the size of the problem, is this a practical approach?
Well, I think that this is just in our group, and this is a retrospective analysis, and it needs to be confirmed in larger studies in a prospective manner, and we're trying to propose the studies to the NIH to do those kind of studies.
Because the results are really encouraging that if you can look and find these patients, maybe you have a better chance of intervening before we go to something else.
Yeah, I totally agree. I think that it's interesting that already this type of drug level is already covered by the insurance. We're doing it a little bit backwards to trying to do it more in perspective and to convince everyone and to see if it can be applied in larger population.
On a somewhat related note, there has been some disappointment in the clinical trial results for renal denervation. Where are we going with that now?
Well, I think that there's still a potential benefit of renal denervation, but I think that if they have not selected people who truly adhere to the treatment, they can have very mixed signals. Actually, in the trial, they did find a reduction with the denervation, but they actually found as much reduction in blood pressure in the people who randomized to the sham arm. And I think that it's very likely if half of the patients they recruited and not adherent to treatment, when they're getting the sham procedure, the study has shown in the past that for the fact of being in the study and being followed up, they tend to improve the health behavior by itself by perhaps eat better or exercise more and taking more medicine. I think that's really a clue because in the Simplicity trial, the MDs are not allowed to increase the number of medication, but I think it's very likely that the control arm, they tend to adhere more to treatment, and that results in improvement in blood pressure.
And perhaps the renal denervation patients weren't adherent in the first place, so maybe they shouldn't have undergone the procedure if they were not adherent to the drug therapy.
That could be very likely. That could be likely.
This is an interesting topic, and like I said, it's one that's not going to go away.
Yes.
The paper itself is in the March 4th issue of JACC 2014, of course. For CardioSource World News, I'm Executive Editor Rick McGuire.